Good morning, everyone. I'm calling to order this hearing of the Health, Finance, and Policy Committee. It's great to see everyone here. It should be a very interesting day today. And we don't have, quorum is present. We don't have any minutes to approve today, so we can get right into our business for today. And the first bill on our agenda is House File 1843, Representative Reyer. And so let's see, there is an amendment. And so Representative Reyer's motion is that House File 1843 be laid over for possible inclusion. And there is an author's amendment in our packet, which is the DE2. And Representative Reyer, I assume you want to move that right away. Am I right? So
yes, Madam Chair.
All right. So Representative Reyer is moving the DE2 amendment, and then when we adopt that, she will give her presentation and explain the bill as amended. So all in favor of adopting the DE2, please say aye. Aye. Opposed? Motion prevails. The amendment is adopted. So Representative Reyer, welcome back, and to your bill as amended.
Thank you, Madam Chair. Thank you, members. I'm excited to have the opportunity to talk about House File 1843 with you today so that we start taking steps to obtaining the information we need to improve our healthcare system here in Minnesota. But before we get into the bill, let's talk about why we're even having this conversation. The top headline, a variation of which many of us have heard many times, the U.S. has the lowest life expectancy among large, wealthy countries, while far outspending them on health care. Just a couple data points. If you look at the average life expectancy for countries like ours, it's 82.4 years. The U.S., 76.1. If you look at health spending per capita, the average is $6,003. For the U.S., $12,318. This is a big red indicator of a problem affecting both lives and money. We know this, and we've spent many committee hours talking about problems in the healthcare system, about rising costs, burnout and workforce shortages, disparities in access and outcome, burdensome processes to receive care. And when I look at the root cause of these issues, I see a healthcare system that, at essence, was not designed to put health first. And I also see a system that's not what anyone would design if they were starting with a blank sheet of paper. Our current system goes back to the early days of the employer-based system. Its initial purpose was to give employers a way to attract workers during World War II wage freeze. These benefits were then made tax exempt, and after a brief repeal in 1953 were enacted into law. While linking health insurance to employment did draw workers at the time, the health of employees was not the primary motivation, and that shows today. Since then, entire industries have arisen to manage the employer-employee relationship around healthcare. Bureaucracy is rampant, and regardless of intent, it puts problematic barriers between the patients and their caregivers. We see this in limited networks and prior authorization. Rare disease access, for one, my House File 384, is just one example. Unnecessary barriers to care have resulted in a diagnostic odyssey of 7 to 8 years, 2 or 3 wrong diagnoses, and seeing an average of 8 clinicians before patients finally get their diagnosis. And more than a quarter of pediatric patients report being denied out-of-network care. We have a tiered healthcare system that provides excellent and affordable access to some, mostly people working for large employers with rich benefit sets. Small companies and individuals make do with lesser insurance plans and pay more, as shown in a recent Kaiser Family Foundation report. The average deductible for employees of small businesses is $2,543, compared with $1,493 for large business employees. What's more, the annual premium Average annual premium for small business employees is $7,556 compared to $5,580 for large employers. Higher premium and higher out-of-pocket costs when you work for a small employer. People on public programs face a different access challenge with limitations created by low reimbursements, as we've seen, for example, with Medicaid dental coverage for kids. We have devastating and avoidable disparities in healthcare outcomes. In Minnesota, Black women are 2 to 3 times more likely to die during pregnancy or within a year of giving birth compared to their white counterparts. Indigenous women are 4 times more likely to die. The infant mortality rate for Black and Indigenous babies is more than twice that for white infants. Plus, we don't get what we pay for. I'll remind you, our life expectancy is lower than other comparable countries, and we pay far more for our health care. This, like other measures, is far worse for Indigenous and Black people. At birth, Indigenous and Black people had shorter life expectancies, 65.2 and 70.8 years, respectively, compared to white people, 76.4. Notice that 11-year life expectancy difference between Indigenous and white members of the Minnesota population. We've seen workforce issues across the healthcare system, exacerbated but not begun by the pandemic. The Minnesota Nurses Association reports that 2,400 MNA nurses left bedside care positions last year. A study published in the Mayo Clinic Proceedings in late 2021 found that nearly 1 in 3 physicians and nurses reported a clear intention to reduce work hours, and that nearly 2 in 5 nurses and 1 in 4 physicians intend to leave their practice altogether. Beyond physicians and nurses, we know that staff at all levels of care and all parts of the care continuum are enduring stress from being short-staffed, and many work for a wage that is inadequate for the work that they do. Now, there are no quick and easy fixes. I'm not here with a bill that solves our healthcare issues. Instead, I'm bringing forward an approach to get the information we need to think about ways to improve our healthcare system. House File 1843 proposes a research study that will compare our existing healthcare system with a universal healthcare plan as proposed in House File 2789, the Minnesota Health Plan. The study will go beyond looking at the cost of providing benefits. The study incorporates broader factors, such as the impact on administrative costs throughout the system and societal impacts. Our approach brings together aspects of studies that have been done in other states and is intended to learn from existing research in finalizing the design. House File 1843 appropriates funds to the Commissioner of Health, and work will be led by our colleagues at the Health Economics Program. We've been working closely together on the design for the study and ensuring the legislation accurately reflects the need and intent. Let me now tell you a few more specifics about the bill, emphasizing that it is a work in progress. As we move through it, you'll get a brief overview of the current healthcare system and a little bit more detail on the Minnesota Health Plan, and then we'll talk about the research design. So my intent today, I see this as a great opportunity to get your first input on what we investigate and how we investigate it. I hope we'll have a collaborative conversation that'll lead to a far better outcome. Also, I would like to count on having conversations with you all after this bill is laid over and as it evolves. So now, thinking about the bill itself and what it covers, if you look at the House Research Summary, it'll be a good resource for you. We start out with some definitions. We define all necessary care. And this is a very broad definition. It does not include cosmetic care unless it's needed for, say, birth defects or other rare needs. It really is very comprehensive, from prenatal care to long-term care, hospice care, everything in between, the whole body, the whole mind, ears, eyes, teeth, all are covered by the Minnesota Health Plan, or would be by the plan as designed. The other definition is total public and private health care spending for this section. This is where it's a really different way of looking at it. It includes all of the administrative costs that are part of the system for insurers, for providers, for employers and individuals, and for government. And so if you think about the provider situation where they have different processes and procedures for their different carriers, that complexity goes away. If you think about employers who have whole teams who are doing benefit selection every year and managing benefit options, that cost and complexity is no longer needed. So this is a really, to me, a rich way of understanding almost for the first time what it looks like when we can have a change that is that systemic. We make a couple of initial assumptions. One is that the new approach is designed around simplification, taking out the complexity in the system. The second is that in the process of doing this, providers will be made whole. We are not looking in any way, and I want to say this very carefully and clearly, we are not looking for providers to have reduced incomes. We're not putting this on the providers saying they're being paid too much. I think that's one of the issues that comes out sometimes around rates. And so I want to make sure that in my understanding, what I want to test is a system that includes providers coming out of this as well or better than they are now. So assumptions for the study. We already talked about how the proposal would be taken care of by the Department of Health. And so if you look in the proposal analysis, this is where we outline all of the different things that we will measure. Coverage, how many people are insured versus uninsured, benefit completeness and underinsurance. We know that many people have coverage, but they aren't getting care. We know many people have an insurance plan, but it doesn't cover too many things, or they can't afford to get the care. So this measures that. System capacity, and measured by whether people are going to emergency rooms because they lack access to proper care. Healthcare spending, of course, and it'll be broken out to the degree possible into different categories for modeling purposes. For example, medical, dental, mental health, long-term care. We'll be looking at changes in the administrative functions in entities in the healthcare system, looking on impact on prices for medical services and products, impact on utilization, on health outcomes and workplace absenteeism, capacity in the healthcare system, and especially taking the care to look at, for example, rural versus urban to see if there are what needs to be done and how a change system would affect that. And then one that is harder to measure, but will be provided at least as a side-by-side impact on non-healthcare expenditures. And this could be things like reduced crime, out-of-home placement costs, the types of societal factors that we believe contribute can be improved by better access to health care. We will not be able to have models that build those in. I don't have confidence in the existence of data sources for that, but I do think that gathering case studies and information from the research out there will be helpful. We'll look at job losses and gains within the healthcare system, especially in the healthcare delivery, billing, and insurance administration, because again, we need to be thinking about the big picture and the employees who could be affected in the businesses. And then job losses and gains elsewhere in the economy to the extent possible. We'll be looking at impact on disparities in access and outcomes. So as we've talked about, it's a major and chronic problem in our system. So one of the areas where the health department and I have been working together is on how we frame the RFP. Rather than what you see in the current DE amendment, it will be designed around first putting out an RFI to gather information from people who may wish to participate. And the reason we're doing that is because we think that there's going to be a lot of brilliance coming from the research community to say, here's how I've done this piece around measuring administrative costs, and I've looked, there are studies out there, for example. Here's how I've done the piece around mental health measurement. And so we want people to come to us and say, here's how I would do this, here's what my data sources are, and from there, put together an RFP and go forward and commission the work. Let's see. So the timing, we look to have this completed by January 15th, 2026. This is not a quick study. This is something that we want to do right, do carefully. We want it to deliver a micro-simulator along with a report so that we can do things like, I'm just going to play, let's imagine if we had a micro-simulator and we said we're going to set prices at the Medicare rate. A lot of places use that as a starting point. We could then say, we could have variables that allowed us to reduce by certain percents for changes, so we could allow things to increase, and we could model the impact on costs and usability, and that's what we've talked about having as a deliverable. So it's not just here's a fixed snapshot. Here it becomes a tool to say, how do we design something that's going to be really a working tool? So I want to wrap up by saying what I'd like our next steps to be is to have all of the brilliance in this room to be part of the process of thinking about how do we get at some of these things. Some are easy, some are hard. When you're, for a researcher like myself, this is like my birthday and Christmas rolled into one, because it's where you can really think about how do we use information to make things better? How do we take a data-driven approach to driving policy? I read a lot of articles preparing for this, and there's a lot of always and never, and it won't or it will, but they're not supported by data. And I want data. I want to have information that we can use to say, here are some good things that we could do, here's what they could accomplish, and avoid avoidable pitfalls. So with that, I think that wraps up my overview, Madam Chair.
All right, well, thank you very much, Representative Reyer. I think even though the bill proposes to study the issue, I think this is really, to me at least, one of the biggest things we're taking up this year, and I really appreciate your taking this on to really step back and look at our whole system. How do these pieces fit together? Everything you went through in your presentation, and that was great. Thank you so much for that. I don't see any testifiers who have signed up, but I would invite anyone in the room who would like to testify on the bill to step forward. Not seeing, oh, there is somebody who wants to testify, so come on down. So please introduce yourself for the record and go ahead with your testimony in 2 minutes, please.
Can you hear me all right?
Yes.
Excellent. So good morning, Ms. Chair and members of the committee. My name is Thomas Lane, and I'm from Excelsior, Minnesota. I support this bill because I'm sick and tired of seeing our state suffer needlessly from preventable causes. As the son and grandson of 3 different small business owners and a third-year economics student at Dartmouth College, this bill excites me because it's a promising idea to solve one of the biggest problems facing our state, our nation, and our economy. The problem is our healthcare system. As it stands now, we pay ridiculous prices and we get ripped off. It's time to take agency back into our own pragmatic, honest, and down-to-earth hands here in Minnesota. The big picture here is we pay far more for care that leads to solidly mediocre results compared to our peer nations. It's an embarrassment, and it also puts our businesses at a competitive disadvantage. How does that work? In our peer nations, businesses don't have to worry about healthcare like they do here. Their health insurance is managed by something similar to what this bill would study. They are free to focus on their trade and offering the best product for the best price. In the United States, by contrast, businesses of all shapes and sizes are expected to somehow also be masters of health insurance. Somehow they're supposed to find a plan to offer their employees amongst a myriad of different overpriced options with ever-shrinking benefits and networks. It's a massive chore and financial burden that makes it harder for them to do whatever business it is they should be doing best. It's especially onerous for small family businesses like my dad's and grandfather's. Often they just can't afford to navigate the health insurance maze and struggle to hire workers as a result. There's been a lot of talk about labor shortages lately. This is part of the reason why. In a world of insane healthcare prices, workers don't want to work for firms that can't afford to offer them health insurance. I can't blame them. Why would they? This bill studies our most promising and pragmatic solution to that. The Minnesota Health Plan takes the health insurance off the table and liberates our businesses to focus on what they do best. By ensuring that all residents have access to robust health insurance at a price they can afford, we gain a workforce that is happier, healthier, and more productive. This is an investment in our state's long-term future that will encourage economic growth, strengthen our families and communities, make our state a more attractive place for folks to move to, live in, and start business in, and do all of that in the most cost-effective manner.
Ask you to
Thank you
wrap
for
up,
your
please.
listening, and I'm happy to answer any
All right.
questions you may have.
Thank you so much for your testimony. Is there anyone else who wants to testify on the bill? Please come down. If you, other people in the room, if you do want to testify, please get ready to come down so that we can reduce the time between testifying. Welcome to the committee. Please introduce yourself and go ahead. 2 minutes, please.
My name is Dave Garibaldi, and I am a volunteer with Healthcare for All Minnesota. Madam Chair and committee members, the U.S. healthcare finance system is more wasteful and inefficient than that of any wealthy, developed country in the world. Indeed, we pay twice as much as any of our peer countries while leaving millions uninsured and underinsured. We lose an estimated 45,000 lives each year because we refuse to fix this broken system. Medicare debt accounts for over 500,000 personal bankruptcies every year. There is a better way, but powerful special interests will lobby against it every step of the way. There will be no limit to the fear-mongering, distraction, and disinformation they will spread in order to save their golden goose. But reality overwhelmingly and clearly supports a simple, high-quality, universal, patient-centered financing system. The study described in HF 1843 will undoubtedly substantiate that such a system will provide better, more comprehensive and equitable care while reducing the overall cost to government, Main Street businesses, and individuals. How do we know this? Well, all you need to do is look at the facts. A 2012 study commissioned by the Minnesota group Growth and Justice and performed by the well-respected Lewin Group confirmed that a single-payer system could indeed cover all Minnesotans for less than our current system. Traditional Medicare has a 2% administrative cost compared to 12 to 18% for the commercial substitute called Medicare Advantage. Prescription drugs cost twice as much in the U.S. as they do in our peer countries, yet we have forbidden Medicare to negotiate drug prices with pharmaceutical companies like those of other wealthy countries do. Cost of care for individuals in our VA system averages thousands less per year than individuals in our private healthcare system.
I have to ask you to wrap up, please.
Thank you. The nonpartisan CBO, Congressional Budget Office, has projected a multi-trillion-dollar savings under a single-payer system compared to our current system. There is a famous quote attributed to Winston Churchill that Americans will always do the right thing after they have tried everything else. Well, folks, we have tried everything else. It's time to do the right thing. Support HF 1843, and thank you.
Thank you for your testimony. Is there anyone else who wishes to testify on the bill? Please come down. Welcome to the committee.
Hi, my name is Matthew Lowen, members of the committee chair. I am a student at the U of M in the public health program. I don't have any prepared remarks, so this is impromptu, but I personally echo what the other testifiers and Representative Reyer have said about how a single payer system would be much better, and I personally support that. But this study is really important to get the facts and data that we need. And I think that's what this bill does, is it creates the study that would give us very specific information for our state, because there's a lot of studies that from California and other places that have attempted this, and it's an extremely complicated issue with reimbursement rates, Medicare waivers, all the different things that would be needed. And I've written several papers in my program about this because this is an area of great interest to me. And what I've learned through my studies is that it's all very complicated, and I think that's why this bill is an excellent bill, because it would give us the data specific to what we're thinking about doing in the state of Minnesota, and it would give us data that we don't have to rely as much on what California did or what Vermont did or other states, and it would be a great way for Minnesota to plan and have good budget numbers and all the different variables, because it has the micro simulator that lets you look at different reimbursement rate models. And overall, I would just say from a public health perspective, this would be an excellent bill to help address inequities and start fixing some of these large structural problems with the healthcare system. So I support this bill, and I would encourage the members to as well. So, thank you.
Thank you for your testimony, and please be sure to let the pages, they have a sign up for witnesses, so if you would make sure we get your data before you leave, it'd be great. Anyone else would like to testify? All right, I'm not seeing anyone, so we'll close the testimony now and go to member discussion. Representative Perryman.
Thank you, Madam Chair. I just have a few questions. First of all, I've been accused of analysis to paralysis. Not that this is it, but I do like data in my business too as well. So thank you, Representative Reyer. I am just going to open up with the open appropriation. I know that you appropriated $500,000 last time around. Are you thinking it's about the same amount, or no idea?
Representative Reyer.
Thank you, Madam Chair. We think it'll be more than that, but that'll be a outcome also from the RFI to find out what can be done and what the cost would be. But that's not to say it's a blank check. Maybe $1 million, maybe a little more, but we're not talking 5, 6, 7 million or anything like that.
Thank you.
Representative Perryman.
One more question, Chair?
Please.
Thank you, Chair. And also in the bill, it says to choose one or more independent entities to conduct the analysis. Last time it was the University of Minnesota to conduct the analysis, or are you going to open it up for bidding of entities to take that bid or to be offered the bid?
Representative Reyer.
Thank you, Madam Chair. Thank you, Representative. That's a great question. Yeah, to me, it's not so much as opening up the bid as opening it up to all of the ideas that could be available. And so I do want to have the opportunity for people who may not be affiliated with the U, but of course there are great researchers and great thinkers at the U, so they would also, I hope, will be excited about this.
Thank you. That's all. Thank you, Madam Chair.
Thank you, Representative Perryman. Representative Murphy.
Thank you, Madam Chair. Thank you, Rep. Reyer. I have a question just about, looking at identifying fraud, ahead of time. And if we're going to study everything about a program, it'd be nice to have a look at maybe where there would be possibilities for fraud. And we have a lot of examples that we can draw from. And so I'm just trying to throw that out there. But it would be nice if we start looking at that. We're trying to represent the taxpayers, dollars too. Our testifier, Mr. Lane, said very wisely, he said, we don't want to be ripped off. So anyway, just put that out there. If you have any comment on that, that'd be great.
Representative Reyer.
Thank you, Madam Chair. Thank you, Representative Murphy. Duly noted. To me, that's an aspect that I hadn't thought about in terms of research design, and I will look forward to wrapping my mind around that and how it plays out in the current world and how it would play out in a different model.
Representative Murphy, anything?
Yeah, I'd like to work on that with you.
Representative Reyer, yeah.
See me smiling?
All right. Representative Bierman.
Thank you, Madam Chair. Thank you, Representative Reyer, for bringing this bill forward, and I really appreciated those facts you started out with, those pertinent facts about our healthcare system compared to other countries. And I think that was a very good starting point for us to understand how we got to where we are today. I'll just share, my son is 26. He is having to shop for his own health care insurance. He left a good job in the city here in Minnesota to take on a dream of going over and becoming a scuba diver. He's being trained for that over in Thailand and exploring the world. He's a bright, curious, educated young lad that, of course, he takes after his mother, but he has been researching healthcare, and he has also been in contact with people from around the world in these places, and he is lamenting the fact that in the United States, our healthcare system is completely broken. These other folks are there doing similar things or traveling, and they've changed jobs 5, 10 times in their lives and long experiences, and he just says, you need to work on this debt. So here we are. We all work on this, and this is my third term, and I picked this committee because I think this is where we can make the biggest impact in people's lives in Minnesota, and we do need to change. We sit around this table trying to do bill by bill, making change, and I think what we often miss is the data analysis that you are speaking to in this. This may be the best bargain of our dollars that we spend this term by promoting this and getting this healthcare study going. And with you taking data from everyone on it and inviting input, that's what we need to do. So thank you for bringing the bill forward, and I look forward to seeing some results.
Thank you, Representative Bierman. Representative Nadeau.
Good morning, Madam Chair. And thank you, Representative Reyer. Your initiatives are always so thoughtful, and I appreciate that. This one is super complex, and all the testifiers alluded to that. And the health outcomes that we have in America, they are significantly less. I mean, we live shorter lives. We have bad birth rates. We have more injuries, more homicides. Our heart disease rates are higher. Hypertension is out there. Obesity is higher than anywhere. We have chronic lung disease. Yep, all bad health outcomes. And what we do know, however, what we do know is that the things that do work in certain places require, those trust-based relationships, that person-centered care that we have. And what I'm seeing in this, and I kind of like it, I mean, I think I do like it, actually. I'm not quite sure what it's going to cost. I think it's incredibly robust. I worry that it's kind of a shotgun, crowdsourced, base policy that we're going to try to bring all these things in, and I'm not trying to be disrespectful at all. I mean, because it's so complicated. But it seems like it's focused on treatment interventions and the cost of those, rather than ultimately what we're searching for is health outcomes. And if we can add that component to this, is that we don't, yes, it's costly, it's complicated, it's difficult, it has all these partners that always work together. I mean, today, we've got 4 bills today that are going to change, maybe. I mean, we're going to possibly look at a MinnesotaCare buy-in. We're looking at increasing people having access to our insulin program. I mean, we make these changes every day. I mean, we're kind of at fault for the complexity that our healthcare system is in. We are, right here at these tables. And so hopefully we can learn to control ourselves moving forward a little bit. Maybe we can put everything on hold until your study's done. I think there'd be a lot of people that might enjoy that. But the thing that I want to point out is that I would add, if this moves forward, is that we really, the biggest, I understand that we're looking at the treatments and the costs, and we know that it's massive. But we also add health outcomes and how we get there. And a lot of those things are, those are personal choices. And maybe if we can't get there, maybe we'll all end up going to Thailand and learning how to scuba dive. But I would only offer that because, like I say, I recognize the complexity of this. I think it's a robust approach. I would like to see a dollar figure identified and some further details in what we're gonna try to identify, what is available. But thank you for bringing the bill, and thank you, Madam Chair.
All right, thank you, Representative Nadeau. Representative Elkins?
Thank you, Madam Chair. Every single one of us that's sitting at this table is here because we asked to be here because we feel passionately about the issues.
Madam Chair?
Oh, I'm sorry, yeah, Representative Elkins she's saying she can't hear you well.
I'm sorry.
Yeah,
The mic,
here,
pull
just don't-
it close if you
Does
can.
this one work any better?
No,
Be really close to
It's the
yours.
no,
room.
just be really close to the mic.
Yeah,
Just be
I think this one's dead.
yeah.
I'll try this.
Okay.
No, is that better?
Yes.
Okay. Who knows?
Rip it out of the table, it works better.
No, I was saying, every one of us who is sitting at this table is here because we asked to be here because we feel so passionately about these issues and the bills that we bring forward to address them. But, too often I think we're left to speculate in many cases about what the impact of our bills would be. And I think that with this bill, Representative Reyer has come up with a comprehensive study that would help us provide us a lot of the empirical information we need to make better informed decisions. So I strongly support this.
All right, thank you. Representative Backer.
Yeah, thank you, Madam Chair. And thank you, Representative Reyer. I know you're passionate about this. My question is how do we know that when whoever's looking at this, because it is an important issue, that we're working on facts instead of just theory? You mentioned we'll listen to all ideas, and ideas are important. I'm not saying ideas aren't, but at the end of the day, an idea is not something that's been proven. So how do we focus on what's your thoughts behind that, please? Thank you.
Representative Reyer.
Thank you so much, Chair Liebling and Representative Backer. So when I say we want to hear ideas, what I mean is I want to hear from someone who says, I'm an expert in doing data analysis around using these data sets, doing these things. That the idea is how do we put together a research design that's data-driven, not that the results would be people's ideas. I am looking at I would say if you look at the type of work that the Health and Economics Group does, if you look at the type of analysis they do, it's that with added on from other disciplines and other areas of expertise. So we can talk more offline if you'd like, but to me it's quite the opposite in my intent. It is quite the opposite of having it be how do we feel about something? Because that's one thing I want to say is that to me, I have absolutely have my researcher hat on, and in looking at this, to me, my goal is to be neutral, is to come in and say, here's how these things stack up. And honestly, I would see it as, and we're using an existing model because you need to have something to react to. But we could be taking other proposals for healthcare reform and modeling them through it. You need to have clearly defined data sources that you're willing to stand behind, assumptions that you've vetted around what changes would be, and all of those things will be as rigorous as the data will allow.
Representative Backer?
No further.
All right,
Nothing
thank
else.
you. Representative Quam.
Thank you, Madam Chair. And anytime we're doing this type of thing, we need to look at the impact to rural hospitals and healthcare because they're financially very fragile. So if there's a shift in the payment structure, because we're built on cost shifting, from some we're paying less than what it costs and others are paying more to make up for it. So I would think we'd need that information out of it.
Representative Reyer.
Thank you, Madam Chair. Thank you, Representative Quam. I think I was channeling you when I was thinking about this because to me it's one of the requirements that we be able to break things out, rural versus suburban and urban, for example, because that's a key factor in making sure that we have a healthcare system that serves everyone as well as we possibly can.
Representative Quam, final.
Thank you, Madam Chair. The main thing that I was looking for is the analysis, because there's a major medical facility entity in the state of Minnesota that over a decade ago didn't take additional, and this was in their, I think, Phoenix location, didn't take additional government program patients because when they did the analysis, that would cause that facility to have financial shortfalls because the reimbursement wasn't sufficient to cover the cost of the care and et cetera. So the analysis needs to really look at if we do a shift in how the structures and balances are with a different program. We need to look at that kind of a structure in paying because maybe it doesn't affect, maybe the hospitals are stronger financially in the metro or other. I just don't want to have 10% of our hospitals go under because all of a sudden we have this new cost structure or payment structure which doesn't sufficiently cover the costs.
Representative Reyer.
Thank you, Madam Chair. Just a quick comment is that, to me, that's the value of this, is that we can look at different approaches without doing them and doing harm unintentionally and say, what does it look like if we think about it this way? What does it look like if we think about it that way? And we can have lots of conversations. I think we'll probably both enjoy it.
All right. Thank you. Thank you. Finally, Representative Smith.
Thank you, Madam Chair. And thank you, Representative Reyer. I agree with the chair. I think as we look back on this session, this is going to be one of the most important bills and actions that we take up. And I thought in closing it'd be good to bring up a story of this past weekend. Every weekend I'm having roundtables with small business owners about the paid family medical leave bill that's moving through the session, talking to them about them. And one business owner, nervous about it, we were talking about it. And then as we were talking, he kind of stopped, thought a moment, looked me in the eyes and said, this is a Band-Aid. Why do we keep just putting Band-Aids on things? And this bill finally says we've had enough with Band-Aids. Let's look how we can stop causing harm. And I'm really excited about it. Thank you for moving this forward, and I fully support this.
Thank you, Representative Smith. So I'm going to just make a brief comment, and then I'll let Representative Reyer have the final word on her bill before we lay it over. But first of all, I'm very pleased with the conversation here today. Thank you, members, because when we look at other countries, the idea of having a universal health system in every country that I know of that has it, it is supported broadly by everyone of every political stripe. This does not need to be a partisan issue. This is an issue that we all care about, as indicated by the good questions and comments from every member who has spoken today. So I'm very pleased with that, because getting information should always be a bipartisan thing, and that is what this bill really attempts to do. I also do just want to make a brief comment that one time a very large medical center that I was in my then district, I was speaking to the CEO. This was maybe 10 years ago, and he told me that they employ 800 people at that time, it may be a lot more now, just to do the billing. just to do the billing. If you think about what the cost of that must be, oh my goodness, that is money that is not going into healthcare. That's just collecting money and, figuring out who's paying, how much should be paid, all of that stuff. So I really appreciate the bill. And final word, Representative Reyer.
Thank you, Madam Chair. I just can't tell you all how much I appreciate your comments and identifying places where you'd like to see more or different, and the support for the general concept. And I just sincerely hope I can enlist people to have further conversations and would love to see this move forward. Thank you.
Thank you. And with that, House File 1843, as amended, is laid over for possible inclusion. So we will move on now to House File 96. Welcome, Leader Long. And since Leader Long is not on the committee, I will move that House File 96 be laid over for possible inclusion. And there is an amendment to, no amendment to the bill. Okay. All right. Well, welcome, Leader Long. Your bill is before us, and please go ahead and present it.
Thank you so much, Chair Liebling. In Minnesota, we believe everyone deserves access to health care, no matter our income, age, race, zip code, or employment status. But we know that too many Minnesotans still don't have access to affordable health coverage. This bill before us aims to solve three problems: to give individuals that don't otherwise have affordable health insurance an affordable coverage option. This often includes the self-employed or essential workers who are juggling multiple jobs. Second, to help small businesses that don't have access to affordable health care offer a plan to their employees. And third, to provide coverage to undocumented Minnesotans. MinnesotaCare has been a successful public health care program for low-income working individuals in our state since 1992. It was passed on a bipartisan basis to expand health care access beyond Medicaid to low-income Minnesotans and is a nationally recognized model. The MinnesotaCare Public Option Bill would simply increase health care coverage and affordability by giving more Minnesotans the option to choose the comprehensive, trusted coverage of MinnesotaCare. This will lead to reductions in uninsurance, underinsurance, and uncompensated care. Average deductibles for MNsure bronze plans were around $7,000 in 2020, and half of those on the individual market chose these plans. Coverage like this incentivizes individuals not to seek care until they are very sick, which can worsen health outcomes. It also leads to uncompensated care for those who can't pay their bills. The bill lifts the current cutoff of 200% of the federal poverty level for access to MinnesotaCare. This cutoff is about $27,000 for a single person or $55,000 for a family of four. So individuals who are now eligible would get access to purchase into MinnesotaCare at an extended sliding premium scale. The bill directs and empowers the Department of Human Services to work with other agencies to do the necessary actuarial analysis. It also directs them to seek a federal waiver and ensure that we receive a pass-through of federal dollars available to subsidize health coverage for this population. Second, the bill requires the Department of Human Services to develop a small business public option for employers with under 50 employees. And third, it removes the current prohibition on undocumented Minnesotans participating in MinnesotaCare. Currently, undocumented Minnesotans are only eligible for emergency medical assistance. The exclusion of undocumented Minnesotans from Medicaid, MinCare, and MNsure is a crisis and a driving force of uninsurance, uncompensated care, and health inequities in our state. And finally, the bill includes an important step towards delivery reform. While MinnesotaCare is a public program, it is operated through contracts with managed care organizations. And this bill requests a report evaluating our current delivery system against other options in terms of the impact on provider participation, coordination of care, increasing health, and reducing racial disparities. The concept of a public option has been around for many years and has broad public support for Minnesotans in recent polls. Healthcare affordability means access, and it means looking at premiums, deductibles, and out-of-pocket costs. We must ensure everyone in our state can have affordable healthcare choices, and this bill, I believe, is an important step towards achieving that goal. Thank you, Chair Liebling, and I know there are some folks who would like to speak to the bill.
All right, thank you very much for the presentation. So we have a number of testifiers, so just going to remind everyone we're going to time you for 2 minutes, and we would appreciate if you would try to stick to that. So first on my list is Dr. Catherine Guthrie, and then I have Laura Zabel and Kate Lynch. So please be ready to come up, and we can move a little bit more efficiently if folks are ready. So Dr. Catherine Guthrie, and then as folks come up to the table, if you would state your name for the record, tell us who you represent, if anyone, and then go ahead with your testimony. Also, our mics, as you might have gathered, are not the greatest, so you might need to make sure you're heard. So please, welcome to the committee.
Thank you. Appreciate the opportunity to speak to you and compliment Liz Reyer, who is my representative. I'm very proud of her, and I want to talk to you about that. I am a practicing family physician, having come to Minnesota to train. I've been here in practice for 43 years, the first 13 years in rural practice, the last 29 in a safety net clinic in downtown St. Paul, and also training the next generation of family physicians. I am speaking in a microcosm of what we've been talking about because we see firsthand on a daily basis. I'm sorry, I'm challenged here with having surgery next week on my eyes. What the effects of underinsurance and lack of insurance are on an individual basis, and I strongly support the MinnesotaCare buy-in option expansion as an interim step to better provision of health care across the board. The following are real stories of the high cost of or underinsurance that occurred in my own practice and my partner's practice. A 40-year-old man, employed but earning more than the $27,000 cutoff for insurance for MinnesotaCare, noticed a lump in his testicle. Afraid of the cost he would incur, he delayed getting checked. Months later, his initially curable testicular cancer had spread widely, and despite extensive and then expensive treatment, he died. A mother in her 30s found a breast lump. Because she was undocumented, she delayed getting it checked. While a state screening program covered the diagnosis of her breast cancer and emergency medical assistance covered her initial surgery, she had no coverage for the long-term follow-up that is necessary in monitoring a chronic cancer. When she returned to medical care, her breast cancer had spread to her bones. She does not have the option of long-term cure at this point, and she has young children at home. And she is working in the state of Minnesota. A self-employed friend was only able to get insurance for herself with a very high deductible that she couldn't afford. She delayed testing for life-threatening sleep apnea until she was in heart failure. As frontline family physicians, we struggle every day to provide care that our patients are able to afford. We spend significant time in these efforts, time that could be used to serve people in need of care, in trying to arrange cost-effective or cost-affordable care. There is daily emotional cost to us as family physicians and to the young docs we train in witnessing repeatedly these poignant, traumatic outcomes.
I have to ask you to wrap up, please.
Okay. I think the dollars that we will spend in treating delayed and less effective care could be better spent to provide upfront care. I highly support the expanded MinnesotaCare option on behalf of my patients. We do not need to have Minnesotans dying for lack of access to health care.
Thank you for your testimony. Laura Zabel, and then Kate Lynch, and then Gary Werdish. Welcome to the committee.
Good morning. Madam Chair and members of the committee. My name is Laura Zabel. I'm the Executive Director of Springboard for the Arts. Springboard is a 30-year-old nonprofit based here in Minnesota. We're based both in St. Paul and in Fergus Falls in Otter Tail County. We work with 20,000 artists, creative workers, and culture bearers every year here in Minnesota. And these creative business owners are contributing to the economy and culture and health of their neighborhoods, business districts, and communities all across the state. These are the artists who are teaching in our schools and our after-school programs, working against social isolation and elder care, and helping rural communities attract and retain young people, and creating a culture that defines Minnesota as a vibrant and desirable place to live and to raise a family. And like other small business owners and gig workers, artists are disproportionately self-employed and often have really variable income from month to month, which makes it very difficult to access adequate health insurance. At Springboard, one of our core services is providing business and entrepreneurship coaching, and we hear over and over again that one of the primary barriers for these entrepreneurs is access to affordable and useful health insurance. Many artists are forced into health plans with $7,000 deductibles per year on top of other out-of-pocket costs, or they go without health insurance altogether. Artists have really valuable skills to help us build social connection, improve mental health, rethink and reimagine public spaces, and tackle some of our most pressing challenges. But if we're going to benefit from the contributions that artists can make to Minnesota's economy and vibrancy and our future, these creative workers need to be able to make a living and a life here in Minnesota. Expanded access to MinnesotaCare would help many artists make their lives more sustainable and access more reliable and affordable health care for themselves and their families. And passing a public option will help make sure that Minnesota is a place where culture, innovation, small businesses, and local economies can thrive and grow. Thank you.
Thank you for your testimony. Kate Lynch, followed by Gary Werdish, followed by Rolando Juarez Orozco.
Good morning, Chair Liebling and members of the committee. My name is Kate Lynch. I'm an LPN at Health Partners. I live in Roseville, and I'm here to testify on behalf of my union, SEIU Healthcare Minnesota in Iowa. Currently, too many of our patients are forced to buy high-cost private health plans with heavy cost sharing. All too often, caregivers like me watch our patients delay or skip necessary medical care because they can't afford the high out-of-pocket expenses. I work in pediatrics and family practice, and every day people call in about serious health issues. Often, I recommend that they come into the clinic so we can better diagnose and treat the issue. Every day, a few will respond, "I can't afford the copay," or "My deductible is too high." If this bill passes, I will have fewer of those calls. I'm not just here as a caregiver, I'm also a concerned mother. I have 2 adult sons, Martin and Jack, who are 24 and 21. Currently, they are both covered on my health plan, but soon they will age off. I worry that they won't have good health insurance. My son Martin works as a mechanic, and he is already starting to have knee problems. I constantly remind him to get care now while he is on my plan because we don't know what his insurance will look like in the future. I worry that, like many people his age, he will get a bronze plan on MinSure and will be tempted to skip care to save money, or worse, he may have a serious health care problem that either cripples him financially or even worse, that he can't afford to treat. This fear is very real to me. Another member of our executive board, James Holt Jr., had a son, Alex Smith. When Alex aged off his parents' health insurance plan, he started rationing his insulin and died within days. This bill means parents like me can sleep a little easier. Thank you, and please vote yes on House File 96.
All right, thank you for your testimony. Gary Werdish, followed by Rolando Juarez Orozco, and then Bentley Graves. Welcome to the committee.
Thank you, Chair Liebing and members of the committee, and I want to thank Representative Long for bringing this bill forward. My name is Gary Werdish. I'm president of Minnesota Farmers Union. I still work on the farm and help my son on the farm, which we rent to. But a few years ago, we held Rural Voices meetings around the state, and the one thing that, well, I'll back up a little bit. Last year, last fall at our annual convention, or during our policy debate, one member got up and stated, if you really want to help agriculture, you can do something about health care. Not only to help the existing farmers out there, but to pass on to the future generations. A few years ago, we did have some Rural Voices meetings around the state, and the one issue that came forward, the top issue that came forward at every meeting was the high cost of health care. We had one member that testified that him and his wife, they were paying $40,000 a year premium for their health care insurance, plus a $20,000 deductible. That's just unsustainable. As farmers' incomes go up and down, we had one member just recently, the last year or so, had a very serious health issue. Their income was low enough, they happened to be on the MinnesotaCare buy-in. They were able to get their health care taken care of. Without that, they might not have had the health care. Who knows what would have happened then? So this, we had good discussion here. I appreciate the discussion, and this is not the answer. This is not the healthcare answer. We understand that, but it is a help. It's going to help some people, and that I think all of us in this room want to help people. And I, like I said earlier, strong support of this, and look forward to working with you on it.
Thank you. Thank you for your testimony. Rolando Juarez Orozco, followed by Bentley Graves, followed by Mary Krinke. Welcome to the committee.
Chair Liebling, good morning, committee members. I'm going to be interpreting for Mr. Orozco. He's going to begin his testimony in Spanish, then I'm going to interpret into English, back and forth. Thank you.
Okay, thank you.
Sí, mi nombre es Rolando Juárez Orozco. Vivo en South Center, Minnesota, y estoy viviendo en los Estados Unidos desde el 90. Tengo 32 años contribuyendo a la economía de este país, y mi trabajo ha pagado mis impuestos. Soy un trabajador esencial.
My name is Rolando Juarez Orozco. I live in South Center, Minnesota. I'm a member of Unidos, Minnesota, and I have been living in the United States since 1990 for 32 years. And I have been contributing to the economy of this country with my work and paying taxes. I am also an essential worker.
All right, and could you ask Mr. Orozco to please just be a little closer to the microphone? Yeah. Thank you.
Desafortunadamente en el 2015 fui diagnosticado con un problema adrenal. Desde entonces he estado en diálisis 3 veces a la semana y he realizado 18 horas a la semana en el hospital. Estoy 7 años con este problema médico. Estoy causa dificulta que no tenga un seguro médico.
Unfortunately, in 2015, I was diagnosed with kidney failure. Since then, I have been on dialysis 3 times a week, and I spend around 18 hours per week in the hospital. In these 7 years, the medical costs that this has caused have been incredibly difficult since I don't have health insurance.
El no tener un seguro médico de salud significa que constantemente tengo que elegir entre comprar las medicinas que necesito o pagar recibos, mis diálisis, cuales unos deciden, muy difícil tomar la decisión en vivir, depender ambas cosas, además de opciones para recibir algunos tipos de alimentos. Son alimentos que los programas me envían, buscan comidas que enlatadas, vencidas. Las causas no contribuyen en nada a la diálisis que debería llevar por mis condiciones de salud.
Not having health insurance means that I constantly have to choose between buying the medicines that I need or paying to receive my dialysis, which is a very difficult decision to make since my life depends on both of those things. In addition, the options to receive some food are limited since the programs provide me with canned or expired foods which do not contribute at all to the diet that I should be having due to my condition. And this is the last piece.
Las políticas no deberían interferir en la salud, en la vida de las personas. Por lo tanto, es necesario que aprueben la ley para que todos tengamos acceso a un seguro médico. Espero que mi testimonio sirva para impulsar que otras personas se puedan beneficiar. Gracias.
This is why I would like to end by saying that politics should not interfere with people's health or lives. Therefore, it is necessary that HF 96 is approved so that we all have access to health insurance. Thank you.
All right, thank you. Gracias por su testimonio.
Okay.
Thank you. Bentley Graves, and then followed by Mary Krinke, followed by Shawnee Christensen. Welcome to the committee.
Thank you, Madam Chair, members. My name is Bentley Graves with the Minnesota Chamber of Commerce.
First, I want to thank Leader Long for the provisions in the bill that attempt to highlight and address the issues that many small employers have in providing health coverage to their employees. The provisions included in Section 8 of the bill in particular would bring significant relief to small employers across the state, allowing these employers to claim a credit against their state tax liability for a portion of the cost of providing their employees with health insurance coverage, would make their efforts to maintain coverage for their employees and keep them healthy and productive at work much easier in the near term. But we do have significant concerns about the bill's longer-term solution to the problem of rising health care costs, the government-sponsored public health insurance option. Government health care programs like Medicare, Medicaid, and MinnesotaCare pay doctors and hospitals much less than the commercial health insurance plans do for medical services and procedures. As a result, healthcare providers' operations are subsidized by the higher prices paid by those with private insurance, who pay more to offset this differential. Changing programs like MinnesotaCare, which pays healthcare providers significantly less than the commercial rate, into an expanded government-sponsored health insurance option that's available to any Minnesotan, regardless of income, will lead to significant financial impact on the providers and hospitals, especially practices that operate on already narrow margins in rural areas and underserved communities. This, in turn, may further reduce access to critical care and services in some parts of the state. It will also lead to increased costs for those with private coverage, whether fully insured or self-insured, because healthcare providers will likely shift even more costs to these Minnesotans. These changes will only lead to increased instability in the commercial health insurance market in the state and would threaten the continued viability of the individual and small group markets in particular. While we oppose House File 96 in its current form, we look forward to continuing to work with Representative Long and the members of this committee to develop proposals that will bring relief to small employers and their employees without triggering the kinds of unintended consequences that would follow from passage of House File 96. Thank you, Madam Chair, for the opportunity to testify.
Thank you, Mr. Graves. Okay, Mary Krinke, Shawnee Christensen, and then Dan Andreessen. Welcome to the committee.
Thank you, Madam Chair. And for the record, my name is Mary Krinke, and I'm with the Minnesota Hospital Association. I'm here today to express concerns with House File 96. MHA has long supported the MinnesotaCare program for low-income individuals. Over the years, we have advocated for this program, both its payment mechanisms and its eligibility. We do believe the state does have an important role in paying for health insurance for low-income Minnesotans. There is a section in the bill entitled Transition to MinnesotaCare Public Option. Under this section, the Commissioner of Human Services is tasked with evaluating many things. One of those is the reimbursement to providers. The problem is, as the bill is drafted now, the public option provisions start regardless of those recommendations and with no guarantees about what provider payment rates would be. Currently, Medicare pays hospitals in Minnesota about 80 cents on the dollar, and the Medical Assistance Program pays hospitals about 72 cents on the dollar. MinnesotaCare payment rates are usually based on medical assistance rates. An additional challenge right now is that our payer mix is about 62% government payment. It's gone up over the last few years. That means hospitals are very dependent on commercial payment rates to pay us above the actual rates of providing care. Commercial payment rates are frequently twice the Medicaid rate. This is why MHA is opposed to allowing individuals with higher incomes the ability to buy into MinnesotaCare. If eligibility is allowed to be broader without a reasonable income ceiling, current payment rates could jeopardize our healthcare system. There are policy alternatives that I would like to just mention today. One option could be to raise the MinnesotaCare income limit. It has been set at 200% of the federal poverty guidelines for years. That's pretty low. It's $27,000 for an individual and $55,000 for a family of 4. So we could consider raising the income threshold to participate in MinnesotaCare. Another option is to help those who buy insurance on the exchange with their copays and deductibles. Thank you, members of the committee, and look forward to working with you on this issue.
Thank you. Shawnee Christensen? And then Dan Andreessen. And then anyone in the audience, I'll invite people in the audience in addition who wish to testify, and if you are in that category, please get ready to come down. Welcome to the committee.
Thank you, Madam Chair and committee members. Good afternoon, or good morning, I should say. My name is Shawnee Christensen, and I'm an independent insurance agent, and I represent individuals and group employers throughout Minnesota. And today I'm here representing the Agent Coalition, and so we are made up of 4 different industry associations, and we represent about 54,000 individual agents here in Minnesota. And the Agent Coalition would like to oppose House File 96, the MinnesotaCare public option, because it creates an unfair government-sponsored competitor to the Minnesota-based private sector market. And it's unfair for 4 different reasons, the first of which was kind of alluded to in the previous presenter, is about the public option. Ultimately, it's notorious for the low reimbursement rates. As also indicated, a 2021 report from the Minnesota Community Measurement shows that commercial plans pay 207% of the Medicare, of what Medicare pays, and MinnesotaCare actually pays even lower than that. So needless to say, the discrepancy is even higher and more stark. Secondly, the government has no capital requirements. So if you guys get this wrong, ultimately it's the taxpayers who's going to have to make up that difference. There aren't the reserves that are set aside for this program as the insurance carriers are required to be to stay solvent. The third item is the private insurance carriers. They pay the cost of compliance in numerous regulations with which MinnesotaCare doesn't have to comply. And then finally, enrollees in private plans pay a number of taxes that the state programs don't have to pay. So we'd also like to see that that's calculated in how that last loss of tax revenues is also going to affect the fiscal note. These facts account for the price advantages that is being used to sell MinnesotaCare as a cheaper alternative. Lower reimbursement rates will threaten the solvency of our community clinics and hospitals, as an even higher percentage of their patients are reimbursed at a rate that they agree to accept to give care to the working poor instead of the commercial rates that make the system actually work. When the private plans cannot compete, my clients, your constituents, will quickly find that the public option will soon be their only option, and that they will not be happy with the lack of their choices. We ask you to oppose this plan. Thank you for the opportunity to speak today.
And thank you for your testimony. Dan Andreessen, and then I'll invite others from the public. Welcome to the committee.
Madam Chair, members of the committee, my name is Dan Andreessen with the Minnesota Council of Health Plans. We appreciate the meetings we've had thus far with Majority Leader Long on this bill, and look forward to continuing those conversations about aspects of this bill. We do support some provisions in the bill, including the provision to expand eligibility for MinnesotaCare to undocumented residents. But we do have concerns about other pieces of the bill, mainly that we'll be studying a buy-in option while implementing at the same time. And we would urge to first do the study and then come back and implement it if the study, depending on the results of the study. We do appreciate the language that's in there regarding a study, but we do feel like there's a couple pieces that need to be expanded. First of all, the report should be conducted by a neutral third party who has experience in actuarial modeling to estimate enrollment, anticipated premiums, out-of-pocket costs, as well as broader market impacts, market stability, adverse selection, and so forth. We do have concerns, or we probably need some clarification on reimbursement that's been mentioned before. It looked like the preliminary fiscal note is assuming that Medicaid rates stay what they are. One thing I would probably add to this is that keep in mind that hospitals, if patients arrive in their emergency rooms, they have to treat them. Providers have a little more discretion on who they see through their door, and we've already seen situations where providers tend to favor commercial patients over Medicaid because of that reimbursement, and dental is just one example. We also want to look at the coverage and utilization differences between commercial plans and MinnesotaCare. We think that there are some differences. Also looking at the state budget impacts, I think in the preliminary fiscal note it said that the Healthcare Access Fund would be kind of the backstop if there wasn't enough money to pay claims. So that would be something that needs to be maybe looked at more, because health plans need to hold a 3-month reserve to make sure claims are always being paid. In closing, I'd just say as we go forward, we should not just assume that MinnesotaCare's buy-in is the only option. We should look at other options as well. And if the goal is to move everyone to a 94% actuarial value product, which is what MinnesotaCare is, we could also look at market subsidies to get people to that level. But look forward to continuing conversations on this bill. Thank you.
Thank you for your testimony. Is there anyone else from the public who wishes to testify on the bill? Okay, I'm not seeing anyone, so we'll close the testimony then, and we will go to discussion. There is an amendment in the packet. I think we should probably, if someone cares to offer that, Representative Schumacher.
Thank you, Madam Chair. I will offer the A1 amendment.
All right, the A1 amendment has been moved to your amendment, Representative Schumacher.
Thank you, Madam Chair and members. The A1 amendment takes a measured approach to this proposal. It taps the brakes on the implementation and really focuses on the study piece. I know a lot of times around here we argue that a study can just kick the can down the road on an issue and not really deal with it. And, sometimes I would agree with that, but this isn't the intent with this amendment. It's not to do that. It's when I look at this and I count the votes and the nature of the political ideologies around here, just like everyone else, we know it could be implemented today, and that's the reality that we have. My attempt here is to pause the implementation piece of it and focus on the study because of mainly the largest fact that New York is the only other state that has a basic health care plan, and that no other state has tried to use the expansion of their BHP to pursue a public option. The public should have a clear picture of what this public option would look like, what premiums might be, or the potential impact on those currently served by MinnesotaCare or the individual market. The reimbursement rates that we heard about in testimony, too, the public should have a better picture of that. These are things I would hope we'd all like to know before the implementation, and this amendment gives us that ability. There are a number of questions that no one really would be able to answer right now, like what providers would be forced to participate, or if providers would be forced to participate in a buy-in network. Will the federal government provide some level of support with the proposed implement changes? Are there implementation changes that are allowed under federal law? What would DHS need a federal waiver for? Does federal law need to change to support this implementation? And how would we go about making those changes, or how would the department go about requesting those changes at the federal level? Members, this is a big proposal. We've heard from supporters and opponents this morning, and some come from a place of testimony from their own personal experience. Some come from a place of an emotional appeal for this, and others come from research, but of other areas. It's not Minnesota. This, again, is the only state in the country attempting to use their BHP for their public option. The votes are there to do it, and I understand if it's going to be done, we need to get it done and done right from the start. If we don't, we have the ability now to temper the concerns from those who are currently opposed to the bill, and the concerns that they raised today, we can temper those by studying first. And really, for those who spoke in favor of it today, we want to make sure that we don't let them down in the process. They see this as a real solution to their problems, and we don't want to let them down. And so for that, members, I'm asking for support that we focus on the study piece of this, get the answers that we need to implement this and implement it the way that the study would support, and I would ask for a roll call.
All right, a roll call having been requested, there will be a roll call. Leader Long.
Thank you, Chair Liebling. Thank you, Representative Schumacher. I appreciate that you didn't delete the whole thing, and there are some pieces you still like that are left over. But I do think that this would significantly limit what we're attempting to do with the bill. There are portions that we're studying that we're not going to be directly implementing, and the legislature would come back, and that includes the delivery reform study, for example. But having a public option that is going through MinnesotaCare is the point of the bill, and the studies that are being conducted to get to that point are going to make sure that it can be executed well and meet our goals, and we'll take the time we need to make sure that that happens with the bill rollout. If there are things that go wrong in the interim, like the federal government not providing a waiver, we can always come back and address that as a legislature. But I think we have a a lot of confidence that we're going to be able to move forward with a waiver. We've had success with waivers in the past, and I do believe that the study and the timelines and process we have set out in the bill are workable.
Okay, and I would just say as well that, this is a big bill, and we're trying to do a lot of big things this session, and we are laying the bill over. I know that there's still continued work going on. So with that, the clerk will take the roll.
Chair Liebling.
No.
Liebling, no. Vice Chair Bierman.
Bierman, no.
Bierman, no. Lead Schumacher.
Aye.
Schumacher, aye. Representative Acom.
Acom, no.
Acom, no. Representative Backer.
Aye.
Backer, aye. Representative Bonner.
No.
Bonner, no. Representative Carroll.
No.
Carroll, no. Representative Elkins. Elkins, no. Representative Fisher.
Fisher, no.
Fisher, no. Representative Hemmingson Yeager.
No.
Hemmingson Yeager, no. Representative Herr.
No.
Herr, no. Representative Keel.
Aye.
Keel, aye. Representative Murphy.
Yes.
Murphy, aye. Representative Nadeau.
Aye.
Nadeau, aye. Representative Brindley. Excused. Representative Perryman.
Perryman, aye.
Perryman, aye. Representative Quam.
Aye.
Quam, aye. Representative Reyer.
No.
Reyer, no. Representative Smith.
No.
Smith, no.
There being 7 ayes and 10 nays, the motion does not prevail. The amendment is not adopted. So to the bill, discussion to the bill. Any further discussion? Representative Nadeau.
Thank you, Madam Chair. Thank you, Representative Long. Hopefully you were here at the beginning when we listened to Representative Reyer talk about the big study she's got coming up. I mean, because we heard everywhere about data and how important it is and how complex our healthcare system is. And I wish we would have maybe talked a little bit further about Representative Schumacher's amendment. I think it would have served us well. The complexity of our system is driven because, your bill is a good idea. I mean, providing more options for people, hopefully, providing more options more cost effectively are going to drive health outcomes. That's what we want. We want to do it. Minnesota has not, well, there are some access problems. We've done well with access. We've done poorly with reducing complexity and providing affordability. The questions that I have for you, I want to start on some of the unknowns, and maybe you can spend a little bit of time trying to help me with this. On page 7 of the fiscal note, it would be the 4th paragraph under establishing a public option program for MinnesotaCare, talking about the limited data to inform an estimate of how many individuals will choose to enroll in the public option. And it goes on to say that it's roughly 21,600 individuals. And do you think, will this be further vetted by actuaries in your bill under the section, I think it's section 10 of your bill, prior to the commissioner moving forward with this?
Representative Long.
Chair Liebling, Representative Nadeau, yes, there is a full actuarial analysis that is paid for in the bill and will help inform the premium scale and help inform the rollout of the public option.
Okay, and thank you.
Representative Nadeau.
And moving on to the next page, page 8, again, 4th paragraph down, assuming that we do receive the 1332 waiver, which, assuming that we do receive that, looking at the tax credits, the 95%, so the state is going to capture that value that would have been provided to those individuals who would have been able to use that to purchase their own insurance. Do we have any idea of that, of that expansion? the 5% that we're not capturing that would have been available to individuals to use to cover healthcare expenditures, co-pays, deductibles, do we have any idea of the amount of money that we're talking about by individuals foregoing that 5%? And would that also be identified theoretically by the actuary?
Representative Long?
Chair Liebling, Representative, I don't have that answer, but I'm happy to find out and get back to you.
Okay.
Yeah, and Representative Nadeau, I wouldn't be surprised if somebody does have that number, because, this is the same sort of process that we use now for MinnesotaCare under the waiver, and we capture that money, and so it's all calculated, I believe.
Yeah, I was just curious about the delta. Yep. I guess, because I think it's in the 20s to, I think it's lots of millions that we're basically losing, that people lose by going to a public option. I just think it should be a component of it. And my last question, or maybe it's more of a statement, Madam Chair, I'm worried. There's a lower reimbursement rate with MinnesotaCare to providers, and I don't know if that will be addressed in here. We do know that it is a lower rate of reimbursement. And that is going to be difficult and harmful to our providers who work hard to try to provide services to a population that to everyone. And so I'm wondering if your bill, or as we move forward, if you can try to address, is there an anticipation that there's going to be increased rates to providers, because right now it's a significant decrease rate to those providers, and now we're going to expand that population where the state is going to reimburse at even lower levels, and I'm concerned about that. I can't put a number to it. I don't know what it is. I wish I could, but do you see, as we move forward, we try to identify that and recognize what that may be? So that we can try to, also make our providers whole in this situation?
Representative Long.
Chair Liebling, a few comments, Representative Nadeau. So first, reimbursement rates are certainly one part of the puzzle here, but we are also going to be reducing uncompensated care with this bill by having more individuals who have insurance that will pay for the care than under a bronze plan, for example, or for undocumented residents. They don't have any real ability to help pay for care. So it won't all be in one direction necessarily for providers. I'd also note that there are a number of provider organizations that do support the bill as it is, including the family physicians and pediatricians. So there isn't unified concern there. But I do take the concern seriously about overall reimbursement rates. As Chair Liebling mentioned, this bill is being laid over, and we're continuing to have conversations with stakeholders about how we might address some of those concerns. But the goals of the bill, I think, are clear, which is we want to help get people access to care, and I think that's a shared goal of everybody who was up here today.
Representative Nadeau, anything further?
Thank you, Madam Chair.
All right, thank you. All right, I'm not seeing anybody else. Oh, yeah, Representative Bierman, and then we'll go to Representative Long to close up.
Thank you, Chair Long, for carrying the bill. I wanted to just reiterate, what Mr. Wordish had said, that I agree with Mr. Wordish that this is not the end all for curing our healthcare ills. We all know that. And I hope you've enjoyed your time in committee today listening to this tangle that we work with every single day, and appreciate you trying to bring this forward to help, because it will help thousands and thousands of Minnesotans to access the very care needed, and hopefully reduce those emergency costs, which they go to the emergency room when they don't have health insurance. So that's a big help. And we just have to continue to work as a state and as a government to make sure that our people have the health care that they need when they need it. This will help many, many, many people until we as Americans do what Mr. Churchill said and try everything else before we get to the answer. So thank you very much for being here.
All right, Leader Long, final word.
Thank you, Chair Liebling. Appreciate the good discussion today. And I think you heard from many of the testifiers what the need is out here, that we have individuals in our state who are not seeking health care because they don't have access to it, because they can't afford it, they can't afford the copay, they can't afford the deductibles, and that shouldn't be acceptable to any of us in this room, that we have individuals in Minnesota who are getting sicker or who are dying because they aren't seeking the care they need or they're not getting the treatment they need. So I certainly agree, Representative Bierman, this isn't the whole answer, but I'm hoping it's part of the answer. And I think there are pieces in here that we heard almost universal support for today, and there are pieces of here that we probably don't have universal support for, but I think it's all moving in the right direction of expanding access to health care coverage that is going to actually let people get the care they need and seek treatment in a timeline that will keep them healthy and get them the best coverage they can. So thank you, Chair Liebling, for the consideration today.
Thank you, Leader Long, for bringing the bill. And with that, House File 96 is laid over for possible inclusion. We will move now to House File 2705, Representative Pérez-Vega. And, yeah. Oh, very good. And folks in the room, as you leave, if you're leaving, please be quiet so we can continue with our business. Thank you. And Representative Howard is here as well. So welcome to the committee. So because neither of you are on the committee, I will move that House File 2705 be laid over for possible inclusion. That's right? Is that what we're doing? Yes. Okay. So welcome, and please go ahead and present House File 2705.
Thank you, Madam Chair and members of this committee. I'm Representative Maria Isa Pérez-Vega, representing District 65B, covering the capital city of St. Paul and the city of West St. Paul. And I'm presenting HF 2705, modifying identification requirements for the Insulin Safety Net Program. Insulin is a hormone the human body makes to keep blood glucose levels within the normal range. It is made by beta cells in the pancreas. Insulin's main job is to move glucose from the bloodstream into the body cell to make energy. I am one of the estimated 400,000 Minnesotans whose body does not produce this hormone and depend on numerous insulin injections each day to live, to be right here, to be the rep who raps. I have been a type 1 diabetic since I was diagnosed at the age of 16 years old. I have a godson, cousin, who was diagnosed at 5 years old, and a nephew who was diagnosed at 5 years old. We and the many Minnesotans battling this chronic illness have no breaks with this illness. We are constantly monitoring our lives based on the level of our blood glucose with a balance of multiple daily insulin adjustments, giving us a bolus insulin to correct high glucose with insulin, as well as our carb intake with the injected insulin we give. There's no breaks, there's no cure. But there's a blessing through science with the gift of insulin given by injections, which makes us insulin-dependent diabetics fortunate to have the ability to live as best of a normal lifestyle with the access to our insulin either via syringe, insulin pen needles, or the insulin pump. People living with type 1 diabetes and some type 2 rely on insulin as a life-saving hormone. Prior to the discovery of insulin, type 1 diabetics were diagnosed with a fatal diagnosis. Today, the life expectancy for people living with type 1 diabetes has improved dramatically thanks to innovation, technology, and advocacy, though it is still about 10 years less than that of someone without type 1 diabetes. In 2020, Minnesota made history with ALEC's Law, AKA the Insulin Affordability Act, creating the Minnesota Insulin Safety Net Program to help Minnesotans who face difficulty affording their insulin. The program is made up of two parts. One, the Urgent Need Program, in which eligible Minnesotans can receive a 30-day supply of insulin immediately at their pharmacy for no more than $35. And the second program being Continuing Need Program, in which eligible Minnesotans can receive up to a year's supply of insulin for no more than $50 per 90-day refill. I am extremely proud of the work my colleague, Rep. Howard, has led in the legislation with ALEC's Law. And even more grateful for one of my heroes, Nicole Smith-Holtz, whose leadership and dedication through being a mother who lost her son, Alec, due to him rationing his insulin because he couldn't afford it. I'm proud of the grassroots organizers that come together as the known team of David versus Goliath and the Insulin for All Minnesota chapter, who continues to work so that all people are included in this act. That's what HF 2705 brings, the ability for all folks who call Minnesota and make Minnesota home to have access to the Minnesota insulin safety net. Our undocumented community that recently celebrated with honor and humble grace the HF4 driver's licenses for all passing to receive those licenses with our state leading action towards ensuring public safety and human rights deserve to have access to the necessity to live with insulin. Diabetes doesn't have any borders. It affects all human beings. The access to insulin shouldn't have any borders as well. I've met with so many folks in my campaign trail and now as an elected official that are undocumented. I've met with them before my campaign trail because I have guided youth programming for diabetics children who don't have accessibility to these healthcare access that I had as a kid growing up. It's emotional, Chair, because these family members have lost their children. Some of these children have lost their parents, their abuelos, their abuelas. I think about the family who is in my district who are undocumented, and I met while knocking on their door, worked right here in St. Paul, and lived 25 years with their children in high school who were born in this country, and they're struggling to make ends meet to purchase the life-saving medicine, this hormone, that they both need to live. They've asked not to share their names. However, they wanted me to state that they've been purchasing for the past 3 years a pen box of insulin at the rate close to $900 per month for both their rapid-acting insulin of Novolog and long-lasting insulin of Lantus. The married couple end up purchasing one of the vials to share, causing them to ration their insulin and gamble with their life. I have phone calls, emails from so many undocumented folks regarding themselves or their children, crying as they fear being a life lost too soon to not have access to the life necessity of insulin. If you don't have insulin, you die. It's not a matter, you can go a week, you can go 2 days, 3 days, you're gambling. It's our water, it's a human right, and every human being should have accessibility. And with this great Insulin Affordability Act that was passed that many of my colleagues who aren't the freshmen in the room had the great being of voting for it and making it the first in this country, I ask for you to support HF 2705 today.
All right, thank you. Thank you, Representative Pérez-Vega. Representative Howard, did you want to say anything on the bill?
Chair Liebling, I just want to make a few comments. I'll be brief. First, I just want to say that I literally met Representative Pérez-Vega, I think at this exact table.
That's right.
She came up to testify as a citizen for Alex Law, and I'm just so grateful that she's here as a member fighting for this bill, and I'm grateful to support it. Chair, as you know, we spent more hours than we choose to probably tell negotiating Alex Law, and this is a piece of it that we fought very hard for, that we didn't get across the finish line. And it was hard and cruel, because I do believe that this is about saving lives, a safety net program to save lives, and that should be accessible to everyone, no matter of your status. As Representative Pérez-Vega said, you know, type 1 diabetes has no borders. This should be a program that's accessible for everyone, and I'm just so grateful for Representative Pérez-Vega to continue to push for this, and I'm here to help answer any questions as the author of the original bill and law that is right now saving the lives of Minnesotans.
All right, well, thank you very much. So we have a couple of testifiers who signed up, and so I'm going to call up Julia Davis, followed by Rebecca Larson. I'm going to have to ask you to be very brief. We have 2 more bills we need to hear in the next 20 minutes, so we're going to want to move a little bit quickly. So welcome to the committee.
Thank you for the time today, everybody. My name is Julia Davidson. I'm a type 1 diabetic, and I was diagnosed when I was 7 years old, so I've been a diabetic for 24 years. I get really emotional speaking about this because it is vulnerable, and it's particularly charging to speak about this, as 2 insulin manufacturers recently have said that they can cut insulin costs by 75%. It's ridiculous. So through the passage, I've advocated for the Insulin Affordability Act. Insulin is painfully expensive, and even for those who can't afford it, it's not always accessible. Bottles of insulin shatter, they freeze, they denature in heat. Pharmacies close on the weekends. College students get locked out of the shared apartment where their insulin is stored. Insulin is essential to all diabetics, and its inaccessibility is always an emergency, regardless of the circumstances and regardless of the diabetic. The amendment that's being proposed to this bill is extremely important because it recognizes a bigger scope of diabetic community. I didn't have any sense of diabetic community growing up, and it wasn't until 2019, 20 years into my diagnosis, that I even began to connect with a broader diabetic community. It was an odd day in fall in 2019, and I was leaving Nina's coffee shop, and I picked up a City Pages, and there was an article featuring Nicole Smith-Holt and a story about her son, Alec, and my heart broke reading this story. I'd never met Alec, but he was my age. He was type 1 diabetic. He was my community. And he died rationing his insulin. Reading this spurred me to attend a listening session in Shorewood. I didn't expect to stand up, but there, as here, I shook, I sobbed. I stood up, I told my story, describing my early 20s as a diabetic. I was coming off my parents' health insurance at the same time the cost of insulin was skyrocketing, and I graduated during the 2008 recession with a degree in the arts. You can imagine how all that was going for me. The Insulin Affordability Act would have not only helped me, it would have helped everyone in the room that night and countless others who could not show up. It was a balm to feel connected to other diabetics, people who I had never met and might never know, who were confirming that yes, the trauma of diabetes is real and access to insulin remains at its core. The Insulin Affordability Act is life-changing because it recognizes that while Minnesota's diabetic community cuts across all lines, the need for insulin is consistent. This bill saves the lives of my diabetic community members, people I might not know and people I might never meet. And the amendment within this bill guarantees that the good it's already doing will be able to continue. Thank you very much for your time, everybody.
Thank you for coming to testify today. Really appreciate that. Rebecca Larson? And if anyone in the room wants to testify on the bill, please get ready to come down. Welcome to the committee.
I was determined not to cry today, but I can't guarantee that I won't. Thank you, Madam Chair. My name is Rebecca Larson. I live at St. Paul. I'm retired and also a co-leader of the St. Paul chapter of Indivisible. 25 years ago, at age 38, I was diagnosed with diabetes, and I am insulin dependent. Thank you for allowing me to testify in support of HF 2705. Everyone who needs it should have access to insulin, regardless of citizenship status, because for diabetics, insulin is oxygen. However, we would not be here discussing this bill if insulin was affordable like it is in most other countries, or if drug companies were not gouging diabetics, as even my pharmacist admitted to me one day a few years ago when I was paying over $500 for insulin. Diabetes, a chronic condition, should never have to be managed like an emergency. Yet here we are dealing with the practical realities. The people that this bill would help have run out of options. We should not turn them away and force them to ration insulin or expect them to pay hundreds of dollars for a drug or a hormone that literally costs dollars to make. You can't ration insulin any more than you can ration oxygen. And Minnesota shouldn't be rationing life-saving programs like this one based on citizenship status. So we have a choice. We can do the right thing and allow for emergency insulin to all people living in Minnesota, regardless of their status. These people are our neighbors, friends, family, and coworkers. Or we can do nothing and know that the consequence is that people in our communities will ration insulin, get very sick, and possibly die. I urge you to vote yes for this very straightforward, yet compassionate, humane, and life-saving bill. Thank you.
Thank you for your testimony. Is there anyone else in the room who wants to testify on the bill? All right, not seeing anyone, so we will close the testimony and go to member discussion. Representative Bonner.
Thank you. I'll try to be succinct. Thank you, Representative Pérez-Vega. We've come a long way when it comes to diabetes in this country and dealing with it. Full disclosure, my sister is type 1 since she was age 3. My father is type 2. And my significant other, his father actually died because he gave up on life because he felt he would be too much of a burden to his family. He comes from a Caribbean country, and he didn't want to put that on his family. But, you know, before the Affordable Care Act with pre-existing conditions, diabetics couldn't even get insurance after they aged off their parents. It's virtually impossible, right? And we see in this bill a similar trend in a group of folks who really cannot get access to care, and what that really means. And more specifically, when we talk about rationing insulin, you know, I remember the days of cherishing every little teeny bit in the bottom of the bottle, because we put these limits on diabetics on how much their body's going to need in a given month. It's like looking in a crystal ball. We don't know, right? But if you, gosh, heaven forbid, you have to use even one more drop than what's in your vial, and you save every single drop in every single vial because the next month you might need a little bit more, right? We have whole groups of folks who would actually look to trade insulin when someone would run short. And this bill, I think, is a really good step at looking at how we address some of these inequities, some of these really serious issues. And so I really want to thank you for the courage of telling your story, for the testifiers today telling their stories, and really bringing this issue to light. And thank you for all of that. It's a really good start.
All right, thank you, Representative Bonner. Very, very brief final word, Representative Pérez-Vega.
Thank you, Madam Chair, and thank you, Representative Hahn. I know that feeling. It's a family. It takes a family. Just keep it brief. I need insulin when I get out of here. And I'm laughing at that, but it's not really funny because there's a lot of folks that don't have the accessibility that I do, and that's who I'm fighting for. That's who we're fighting for as a state. We can do this. It shouldn't be us as diabetics or family collecting our vials and the little bit that's left to give to these children and their families that don't have documentation. The documentation that they do have is that they're human beings, that they have life, that they were born. So let's move forward and let's make this right for everyone that makes Minnesota a great state.
Thank you for bringing the bill. House File 2705 is laid over for possible inclusion. Next, we'll have House File 2924, Representative Herr. And Representative Herr moves that House File 2924 be laid over for possible inclusion. And Representative Herr, to your bill.
Thank you, Madam Chair, and I will be fast. I'm going to try to make a record here. Thank you, Chair and members, for hearing House File 2924. I had a whole bunch of remarks prepared, but I'm not going to say any of it. Just that this bill provides timely updates to medical assistance, hospital inpatient fee-for-service reimbursement rate setting process at the Department of Human Services, DHS. Specifically, this bill does two things. It transitions the required inflation of hospital MA fee-for-service rates to process that more accurately accounts for current patient care costs, and two, it rebases all rural critical access hospital MA fee-for-service rates to 100% of their actual patient care costs. That's the gist of it. I'm going to have my testifiers come up. They've been briefed to be brief, so come on up, testifiers.
All right, very good, thank you. That was a good example of speed reading. Joe Schindler, and followed by Janet McCarthy. And if Janet McCarthy could please be ready to come right up. Welcome to the committee.
All right, well, thank you, Chair Liebling and members. I am Joe Schindler, and I'm the Vice President of Finance, Policy, and Analytics at the Minnesota Hospital Association. And I appreciate this opportunity to present on House File 2924 to you today. The bill provides timely updates to the medical assistance hospital inpatient fee-for-service reimbursement rate setting at the Department of Human Services. Specifically, it ensures two things. It ensures inflationary adjustments to hospital MA fee-for-service rates to better reflect the current costs in the system. And secondly, it would impact all rural critical access hospitals by bringing them all to 100% of their actual fee-for-service patient costs. These changes are indeed timely because Minnesota's not-for-profit hospitals of all sizes continue to struggle with the long-term financial repercussions of the COVID-19 pandemic, an unprecedented rise in labor and supply costs, and an increasing patient acuity and complexity. All this combined has begun to erode the health care that Minnesotans rely on at their time of greatest acute care need. In 2022, over 30% of hospital inpatient medical assistance patients were covered on fee-for-service, which disproportionately covers health care for children and individuals of all ages with disabilities. It is important to ensure that our medical assistance continues to serve all low-income, vulnerable Minnesotans that need it. And currently, MA fee-for-service only covers, in terms of payments, 71.9% of the actual patient costs to hospitals. This is based on cost, and this is calculated by the Department of Human Services. House File 2924 and its proposed updates to the MA fee-for-service rate setting process will help our hospitals face the extreme pressures they're facing while serving Minnesota's MA population 24 hours a day, 7 days a week, and 365 days per year. Thank you, Madam Chair and members, and I urge you to support House File 2924.
All right, thank you for your testimony. Janet McCarthy. Welcome to the committee.
Thank you, Madam Chair and committee members. My name is Janet McCarthy, and I am the manager for reimbursement at Children's Minnesota. Thank you for the opportunity to join you today to express our support for House File 2924. Children's Minnesota is the largest pediatric healthcare provider in the state, serving more than 166,000 kids annually with emergency care, primary care, and more than 60 pediatric specialties. The number of Minnesota children depending on medical assistance for care is increasing in our system and in hospitals across the state. Currently, 51% of the patients we see in our hospitals and clinics are enrolled in Medicaid, and of those, about 1/3 are fee-for-service Medicaid. The portion of our patients that rely on Medicaid has also been on a steady increase. Reimbursement rates for Medicaid are lower than the actual cost of providing care, typically covering about 70% of our cost. As a part of our mission, we do not turn away anyone seeking care, but this means that Children's Minnesota loses more than $100 million a year in uncompensated care. The proposed changes in House File 2924 ensure that Medicaid rates are calibrated more closely to the actual costs of care delivered by accounting for current inflation. The calibration is essential to our ability to continue to provide services to the communities we serve. Thank you, Representative Herr, for your leadership on this bill.
Thank you for your testimony. Is there anyone else who wants to testify on the bill? All right, not seeing anyone, so closing testimony, and is there a discussion to the bill? All right, I have one quick question for this testifier. This is just fee-for-service, I understand, and are the managed care rates to the hospitals usually higher than fee-for-service?
Madam Chair, yes, this is fee-for-service only, which is about 30% of the payer mix of the medical assistance group. And as far as I know, yes, the managed care payments are indexed a little bit higher. We don't know all the payment rates. You know, they're all negotiated, but yes, they are higher. Typically, a lot of times they're pegged off of the fee-for-service system, though.
Okay, all right, well, who? Oh, Representative Elkins.
Thank you, Mr. Chair. You know, I requested and received a report from DHS that does a comparison and found that generally, yes, the managed care rates are typically a little higher than the Medicaid rates.
Okay, thank you. All right, with that, Representative Herr, final word?
Please support the bill. Thank you.
All right, thank you. With that, House File 2924 is laid over for possible inclusion. All right, Representative Smith. So Representative Smith moves that House File 1884 be laid over for possible inclusion. There is an author's amendment, the A1. Representative Smith, did you want to move the A1?
Yes, I'd like to move A1. This just makes this bill more bipartisan than it already is.
Okay, all right. Well, so the A1 has been moved. All in favor of adoption of the A1, please say aye.
Aye.
Opposed? Motion prevails. The A1 is adopted. To your bill as amended.
Yes, thank you, Madam Chair and committee. I'm so excited about this bill. This is to form a task force around psychedelic medicine to advise the legislature on the legal, medical, and policy issues associated with the legalization of psychedelic medicine. Psychedelic medicine is a large field of study around such drugs as LSD, MDMA, psilocybin, ketamine, and a host of others. Many of these drugs were Schedule I during the 1980s war on drugs. They were grouped in with other much more harmful drugs with illicit markets. These do not. And even more than that, we've seen many, many studies across the medical community that show these drugs have incredible potential to help with various psychological disorders, whether it's addiction, whether it is OCD, whether depression, seasonal depression, trauma help. There's a wide range of issues that are incredibly helped with these medicines, and that's why I think we should really start to look seriously at legalizing these drugs in Minnesota. I want to thank specifically Reps West and Hudson, and then in the Senate, Senator Coleman, for making this a bipartisan bill, because I do see this as something that we can work on together. We have limited time here, so I wanted to highlight some things that are in your packets. I put in specifically 2 articles for you to peruse probably later, not in the next 3 minutes or so. But one is by a panel of mostly Mayo doctors, including Dr. Tyler Osterly, who's one of my constituents, that really just highlights the research that is currently being done and has been done on these drugs. It's a really helpful overview of the major advances and really shows you the scientific side of this issue and how it's being worked out. The other one is the New York Times story from last year to show the human side of this. Specifically, this is a story about veterans struggling with post-traumatic stress disorder as well as other chronic illnesses that have been incredibly helped through studies on MDMA specifically and some other psychedelics. So I wanted to give you both the scientific and the human side of this issue as you consider this. Finally, in conclusion, I want to say why I really pushed for this hearing today and in this legislature and why this should be included in our omnibus. We know we have several health crises right now, especially in the mental health field. After COVID, depending on what study you read, either 1 in 4 or 1 in 5 Americans are taking or have taken drugs for depression. And we see this throughout various fields of study. I had doctors in my office this week. I asked them about this, how's mental health. They said worse than they've ever seen. We also know we have an opioid epidemic still happening, and addiction is really hard to break, specifically in the opioid field. But the area of study that is showing the most promise in this is in psychedelic medicine. Finally, all of these, I should say most of these drugs are both cheaper than current treatments that we have, and they're mostly non-addictive as opposed to what we saw with the opioid epidemic that is incredibly addictive. So there's so much positive in this field. I could talk for a long time about it. I really encourage you, especially on this committee, to read these 2 articles to learn more about this field. That's all. Thank you, Madam Chair.
All right. Thank you, Representative Smith. So is there anyone who would like to testify on the bill? All right. Not seeing anyone. 2-member questions and comment. Representative Quam.
Thank you, Madam Chair. And with some of the drugs that were referenced, I know that there's been some anecdotal and other information that some people have. I guess they call them bad trips or whatever. I think anytime we're looking at mainstreaming any drug or medication, we should have a genomic component to make sure that we try and understand what groups of people might be having a bad or adverse effect. There are a lot of really great medicines that 1 in a million or 1 in 500,000 people have a severe reaction to. So anytime we do a type of study or look into expanding or changing, classes of medication, we really need to use the more cutting-edge science to make sure we avoid unintended consequences. Thank you, Madam Chair.
Representative Smith?
I would just say absolutely, echo what Rep. Quam said, and we are doing that currently, we being the medical community, and that is highlighted specifically in the article I referenced. So it's a great thing to bring up, and that's why we're doing a task force.
All right. Well, thank you, Representative Smith. So with that, House File 1884 as amended is laid over for possible inclusion. So we have come to the end of another very exciting hearing. Thank you all for your participation. We are adjourned.